Evening, a 66-year-old female, non-chronic kidney disease on hemodialysis. She does ultrasound abdomen frequently, and in the last ultrasound, they noticed this well-defined round hypoechoic lesion located in the interpolar aspect of the right kidney. Both kidneys are small in size, that is atrophied. The size of this lesion is 2.4 by 2.2 centimeters, and it is hypoechoic. You might notice acoustic enhancement. It seems like a solid lesion, but it might be a complicated cyst, especially that you see the acoustic enhancement. You need to put the color Doppler in it in order to check for internal flow. However, the operator didn't do that. I guess he felt that this is a solid lesion, and he recommended a CT renal mass. Differential diagnoses for such a lesion, given the age of the patient, is renal cell carcinoma, renal cell carcinoma, renal cell carcinoma. Cut it short, just say renal cell carcinoma until proven otherwise. If you like to mention other differentials, you have to include lymphoma, metastases from breast cancer or malignant melanoma, oncocytoma, and poorly differentiated angiomyolipoma. If no flow is noted in such a lesion, also include complicated cyst due to hemorrhage or infection. The reason I've mentioned these other differentials to the renal cell carcinoma is because the most common presentation of RCC in ultrasound is hyperechoic, and only 10% are hypoechoic. So you have to include other differentials. Abdominal ultrasound done for the patient was in 2011, and probably you might see the lesion in the interpolar aspect there. This is picked up retrospectively, and you cannot swear on it if you were doing the case then, especially with the quality of the ultrasound at that time. CT renal mass protocol was performed, and this demonstrated the lesion. The maximum diameter is 2.7 centimeters. Pre-contrast study, it is a well-defined round, almost isodense lesion to the renal parenchyma rising from the interpolar aspect of right kidney. The arterial phase, it demonstrates early, avid heterogeneous enhancement. The portovenous phase still demonstrates heterogeneous enhancement. Now this lesion is exophytic and it extends into the perinephric space, but it does not reach the gyrotous fascia or the abdominal wall. The portovenous phase is to evaluate the renal vein, as the renal cell cancer is one of the tumors that extend to the IVC. The best way to evaluate the renal vein and the IVC is to look at the reconstructed coronal images. Here there is no renal vein or IVC invasion. A common question in all exams is the tumors that invade the IVC. Another common question is how to differentiate a tumor thrombus from a bland thrombus. I will let you guys look it up, as this will help you to remember it. Back to this case, my first differential is renal cell carcinoma, given the age of the patient as well as the enhancement pattern. Other least likely differentials would include an oncocytoma or hypervascular metastases from breast cancer and malignant melanoma. It is not a cyst, it is not lymphoma. The next step is to do the Tnm staging for this case. An old staging criteria were the Robson criteria. Most centers now are turning to the Tnm staging rather than the Robson, including mine. The T-score for this lesion is T3 at extends into the perinephric space but not into the gyrotous fascia, and it does not involve the renal vein. There were no regional lymph nodes and no distant metastases were detected. According to the Tnm scoring, this is a stage 3 renal cell carcinoma. A multidisciplinary team should be involved in such cases, including an oncologist and a urologist. In stages 1 and 2, the treatment of choice is surgery, either partial or complete nephrectomy. In stage 3, if the renal vein is not involved, surgery is the choice with removal of regional lymph nodes. Both ways, this case was discussed by the urologist and the oncologist, and they decided that total nephrectomy is the choice. Especially that the lesion is confined to the perinephric space, the adrenal gland is not involved, no regional lymph nodes, and no distant metastases. However, the patient was not a candidate for surgery due to heart disease, and she cannot tolerate general anesthesia. So another option was decided. Another multidisciplinary team was conducted, including the oncologist, the urologist, and the interventional radiologist. And we decided to do radiofrequency ablation. Radiofrequency ablation can be done under conscious sedation. So we planned a day for the procedure. The patient was admitted the day before. We reviewed her lab work, including PT, INR, and platelet. She was kept fasting for at least 4 hours. You can also keep her on clear fluid diet for 6 hours. The reason for admission is to manage possible post-procedure complications, including bleeding, injuring other structures like the bowel, vomiting, and pain. The interventionist should study the imaging prior to the procedure and should decide the best access in order to do the RFA. Decided that the best approach is to go from the back straight down into the lesion, asking the patient to lie prone. That the right diaphragm is in my way, but with careful preparation and using a coaxial needle, the risk of pneumothorax is very low. With this position, I have enough space between the lesion and the colon, as well as the right lobe of the liver. And as we know from the basics of radiofrequency ablation, the ablation zone should be 5 millimeters from the sides of the tumor. The ablation zone, similar to the surgical zone in operative cases in which a tumor is removed and we have to cut around the lesion to exclude microscopy. The proper ablation zone should range between 5 and 10 millimeters, and this is really important in order to determine the size of the radiofrequency needle. As the companies that produce the radiofrequency ablation devices have different sizes of needles, you have to make sure that you have the proper needle size before starting the procedure. One consists of tines that you push and go through the lesion and resembles an umbrella. In the market, there are 3 types of FDA-approved RFA needles. One I have in my center is Boston Scientific Levine RFA needle, and it consists of distal tines that go into the lesion. The RFA needle is advanced through a coaxial needle until it gets into the center of the lesion, and then the tines will be released, pushing a handle in the end of the hub of the lesion. This will create the ablation area and the ablation zone around the lesion. Conscious sedation was given to the patient, followed by local freezing. Then, a specifically designed coaxial needle was inserted, which allows the Levine RFA needle to go through it. Through this coaxial needle, an 18-gauge side-cutting needle was inserted, and 3 samples were obtained. In renal mass RFA, obtaining a biopsy prior to ablation is mandatory. As noted here, the tip of the coaxial needle was parked at the border of the lesion in order to allow the biopsy needle to fire through the lesion. And after obtaining the biopsy, the coaxial needle was advanced to the mid of the lesion, followed by inserting the Levine RFA needle. As we notice here, the tines. It was done to confirm the location of the needle, followed by starting the algorithm for RFA. A bit complicated, so I'm not going to mention it in this sitting. However, after almost 30 minutes, this is the end result. We notice gas around the kidney, plus fat stranding indicating the ablation zone. The nearby organs are normal and there is no pneumothorax. Following this, the wound area was covered with a band-aid. The patient went back to the ward. She was given PRN medications for pain and vomiting, and she was discharged in less than 24 hours of the procedure. Next step is to do a follow-up MRI within 1 to 3 months to look for any residual tissue, and another session of RFA can be done. This is followed by another MRI after 6 months and then after 2 years to look for any residual or recurrence. Of course, another session of RFA can be done.